My name is Kay Greveson. I am the lead inflammatory bowel disease nurse at the Royal Free Hospital, and I want to share with you our experience of using biosimilars and switching people to biosimilar medication. So as a bit of a background, we have a large tertiary referral hospital over 3 sites, have approximately 4,000 IBD patients with just over 400 on biologics. We have 5 full-time IBD nurses, a specialist pharmacist within gastroenterology, an inflammatory bowel disease coordinator, and also 5 gastroenterologists with an interest in IBD. So I'm going to address different considerations when we switch people to biosimilars based around organisational, departmental issues, professional issues and concerns, and also, importantly, the patient. So from an organisational point of view, we were coming under increasing pressure to reduce costs. There was a rising use of expensive medications and also in high-cost drugs. And in the trust alone, we anticipated that we'd have a 30% rise in high-cost drugs within the trust. Also, nationally, in 2006, there was a review of medication costs and medication bills, and the example that was used in this review was infliximab, where they said that switching to biosimilars would leading cost savings of around 60 million per year. From a departmental point of view, we wanted to increase access and support for patients. We wanted to increase access to medications. We also have a multidisciplinary team that we wanted to develop that further in order to improve the service that we give to our IBD patients. We also looked at counselling pre-switch, what we needed to do for that, and obviously future expansion of the biologics service. When I first started at the Trust 10 years ago, we had about 36 patients on biologics, and now we have around 420. The nursing service at my hospital, we are responsible for the biologics service. We coordinate it, where we are involved with counselling the patients, organising the screening tests for pre-investigation. We talk to the patients and actually book them onto the day case unit for the infusion, so it's very much a nurse-led service. I think as well integral to this was cost improvements. There was a big opportunity for income generation with a gain share agreement, 50% split with the commissioners. So a little bit more about the gain share agreement. How this works is that the cost savings from switching people to biosimilars is split equally between the hospital and the commissioners, which are the people in the UK who fund the medication, who we have to apply for the biosimilar medication for. So with the hospital, obviously, it increases our capacity. We have more opportunity to develop our services. And as a result of our particular gain share, we managed to get more IBD nurses. From a commissioner's point of view, they have budget savings, and hopefully then it would increase to us being able to use more of the high-cost drugs in our hospital. So, alluded to by Alessandro earlier, a lot of the issues that we have is the same as what everybody had. Will the medication be equivalent? Will it do any harm? Will the results be comparable? How do we actually go around the process of switching to biosimilars? How do we support patients in this process? And more importantly, do we actually have the resources to be able to do this? From a patient point of view, we wanted to make sure that we gave them informed choice. We felt that it was inappropriate to do an automatic substitution. We wanted to involve them as much as possible so that they knew what medication they were receiving. Wanted to explain the reasons for the switch, talking about the risks and benefits, and as much as possible reassure them about the evidence that was available at the time. Looking at the information, we looked at what information we needed, when do we provide it, and in what format do we provide it. We decided that we needed to discuss earlier, so sooner rather than later, and that we also needed to do a mix of verbal and written, and also give patients a timeline of when we're going to switch the biosimilar. And obviously the literature needs to be in a patient-friendly format. So looking at the timeline of what we did, the British Society of Gastroenterology came out with their first statement of biosimilars, which was actually a negative one and didn't suggest switching. A few years later, they then revised the statement and recommended that patients can switch, but it would need to be controlled and patients to be informed. So around about December 2015, the team as a whole met and decided that this is something that we wanted to do. We knew that the commissioners would be advising that we use the biosimilar medication. So we started to put a plan into place, and this was very much a multidisciplinary team effort. It was nurses, physicians and pharmacists, and also the commissioners. So we actually signed the contract with the trust for a biosimilar medication, and then started to develop a business case. And I think this was the integral part of it. So the business case was something that we put to the trust and to the commissioners to say that this is what we plan to do with biosimilars. This is how we plan to do it. And also these are the resources that we needed. So on the back of the gain share agreement with the commissioners, we wanted a band 8A post of a lead nurse, which was myself, and also 2 band 7 inflammatory bowel disease nurse specialists. This was the bit that did take the biggest amount of time, and you can see from the timeline that it wasn't until October 2016 that we actually started the switch. But I would say that the full business case that we did was the main thing, and it was the integral part of actually getting the switch in place and getting the gain share agreement agreed. So the actual preparation of switching people over to biosimilars was in 4 phases. The first phase looked at the operational challenges of how we do it. We started off by developing a pathway which gave roles and responsibilities and actually gave us structured steps in how we were going to switch and what processes were involved. We had a plan of switch, starting with new patients, which I guess isn't actually a switch, it's patients who are new to biologics who actually start on the biosimilar rather than the originator, followed by then a planned switch of all patients who are existing on biologics. We looked at traceability, and we felt that this was very important, that we needed to prescribe by brand medication, and that when we were prescribing, the nurses who administered the medication should actually write the batch numbers down so that there was a traceability in case a patient did have a reaction or had any problems. And we also looked at the different challenges faced, things such as rapid infusions, which we do at our hospital with biosimilars, dose escalation medication. We looked at whether patients should still have this or if there was going to be any issues with people on biosimilars. And also any patients that move to another area. We're a tertiary referral centre in London, so quite often we will get people who move into London who may be on the originator infliximab and then need to switch to the biosimilar. So these are all the different things that we took into account when we were planning. We were lucky to have admin support. So with the administrator support, they posted letters for us. We also didn't just rely on the postal method. Our day case unit handed out letters and also information packs to all patients attending for their infusions. And the letters gave specific timelines, gave the reasons for the switch, gave patients a telephone number to contact, and gave patients a timeline as well. Patients also had a contact detail, so if they had any concerns, wanted to speak, it was the IBD Nurse advice line that they had the option to call or email as well. And we also liaised quite closely with our day case unit so that the nurses who were actually on the ward delivering the infusions were aware of what was happening and could also educate the patients. So our pharmacy We liaised, as I said, very closely with them. They were integral at all parts of the switch to biosimilars. IBD nurses, we prescribe, about 40% of the IBD nurses in the UK are independent prescribers. And so at our hospital, we were the ones that went to the day case unit, prescribed the medication and just ensured that things were running smoothly. On the day of the infusion, the day case nurses went through a checklist, ensured that the patient had received the information about the switch, whether they had any questions, and wherever possible, if we were available, we would go down and see the patient if they did have any queries or concerns about the letter they'd received. So again, going back to the traceability and audit, pharmacy were very good at documenting all patients. We made sure that we had a list of every patient that was either new onto biosimilar or when we went over to switching who had switched. We reported any adverse reactions, which luckily we didn't actually have any, really, in the time that we did. And we also had a weekly report at our Biologics MDT meeting. So this is a weekly meeting that is attended by the pharmacists, myself and the gastroenterologists, along with our other IBD nursing team, and we discuss all patients who are on biologics. So this was a good opportunity to sense check and to make sure that the pathway was actually working. As you can see from what I've said, the inflammatory bowel disease nurse was integral in our hospital and a lot in the UK to the biosimilar switch. We were the ones that wrote and developed the patient letter and the information leaflet along with pharmacy. We liaised with the day case unit, spoke to the nurses there, ensuring that they were up to speed. We were the bridging communication between patients, the hospital and the gastroenterologists so that they could ask us any questions that they wanted. And we had joint responsibility with pharmacy for the traceability and audit trail of the biosimilar switch. So phase 2 was a preparation. This was again nurse-led. Some hospitals in the UK had patient panels or focus groups in which the actual patients were involved in what information needs to be provided, what support do we need to give you. We didn't do that as we're just setting up a patient panel, but what we did, as I've mentioned, was the letter and the frequently asked questions leaflet, and we gave them a timeline of events. This is actually the letter that we used. And you can see here where we did the timeline of events and we gave them patients' contact details and actively encouraged people to call us if they had any questions. On a practicality point of view, of the 420 patients, we had a handful of people who called us who had questions about the treatment, possibly no more than maybe 20 patients. So I think most people, when they read the leaflet and looked at the letter, were happy with what we advised. And again, this is the frequently asked questions leaflet that we provided. So the third phase was introducing biosimilars. This was to all new patients who were naive to treatment. We observed their experience, as I mentioned, prescribed by brand name, recorded adverse events and did an ongoing audit for the period of the introduction to biosimilars. The final phase was the complete switch, where we switched all existing patients. It was interesting that Louisa said about doing informed consent. We didn't actually have written consent. Instead, we advised patients that this will be the date which your medication will switch to biosimilar. If you have any questions, please contact us. Otherwise, we took the no contact as consent. And this was approved by our trust and the department. We also looked at fecal calprotectin and drug and antibody level testing prior to the switch, so that if anybody had any adverse reactions or maybe had a loss of response, we would then have a baseline for which to measure. So it's important to learn from past experiences moving forward. And I think when adalimumab biosimilar comes to market, we already have 2-year experience of using biosimilars. So the situation that we're in now is much different to what we were in 2 or 3 years ago, where patients are a lot more aware of what biosimilars are, physicians are a lot more aware of what biosimilars are, and there is some data that is in inflammatory bowel disease from the North Switch study. I think there is a lot more acceptance both from patients and clinicians with regards to biosimilars. Key considerations, particularly with adalimumab biosimilar, is the importance of maintaining effective home care services. And I think that is something that we are looking at now within our trust. We've got the experience of undertaking the switch. Now we need to use that in order to develop our switch pathway for adalimumab and concentrate on how we can effectively use the home care services and make sure there's no disruption. Obviously, traceability, patient education and feedback is essential, and we also need to have regular audit data. It's important to share experiences as well with your local teams, any hospitals in your local area that may have undertaken a switch to biosimilars prior to yourselves. A switch plan and pathway is not only helpful, but I think it is essential. MDT coordination is required. This wasn't a single thing, although the IBD nurses were integral to it. It was a whole team approach to doing the switch. Audit of outcomes is needed, and it's important to, if you are going to look at doing biosimilars, to address the gain share agreement and get a business case in place before you actually proceed to switching.